development of ischemic heart disease. So people use the terms ischemic heart disease, chronic coronary artery disease. They use them interchangeably. There may be subtle differences, but you will find people will just use one or the other, or any of the three. And they're referring to the same type of cluster of symptoms, side effects, not side effects, but coronary effects. And so we'll start with the chronic. Okay, so on page 3, we have primary prevention. So when we talk about primary and secondary, it's important. So when we talk about primary prevention, what are we talking about? Primary means what? With regards to any disease. First, okay, but in terms of therapy, what do we, when we say primary, what do we mean?
First line.
Like acute?
Oh, interesting. Okay, so,
Wrong.
well, I guess it hasn't come up yet. So primary, when people talk about primary prevention, they're talking about no known disease. So you are trying to prevent a disease from taking place, okay? So when we talk about primary prevention, we are trying to prevent coronary artery disease or ischemic heart disease, maybe in a high-risk population. So people who probably have some of the risk factors, because we don't do primary prevention for everybody. We wouldn't do it in you all unless you had a strong family history or some kind of overwhelming cardiovascular risk factors right now. So primary prevention, don't have heart disease. Secondary prevention then would be what? It's established heart disease. Okay, so that we do differently. Okay, so primary prevention, 2 approaches: risk factor modification, antiplatelet therapy. So the risk factors are down there. So you have some that are modifiable, some that are not modifiable. So the ones that are modifiable would be age. So heart disease, unless you have a hereditary or you have a strong family history for early heart disease. So I'll give you an example. When I was at the VA, I had a young man, he was probably 36. He had his first heart attack when he was 21. His mother died at 35 from a heart attack, and several of her brothers had also died. So they had extremely high, I mean, he had an LDL of 450. So normal LDL would be 100 to 130. So very strong genetic predisposition to early heart disease. So if we take them out of the way, then heart disease becomes a disease of aging, like most of our diseases that we see, that they just become, as we succumb to the things we've done to ourselves, or our genetics, our environment, and the aging of organs, then that's part of it. So you have age, you also have sex, so gender. So men tend to manifest heart disease about a decade before women. So during reproductive years, estrogens and our hormones are fairly protective. And then if we don't have any diseases like diabetes or other diseases that increase our risk of heart disease, or we do things to ourselves like smoke, then we're usually, men are going to see it at an earlier age. So greater than the age of 45 for men, 55 for women. Family history we talked about. So you'd want to know from your patients, you would ask them, anybody in your family have heart disease? So then you're going to start listening to what they tell you, and then if they say, well, I'm not sure, so you would ask them, anybody had heart attack, stent, bypass, angina, or died suddenly of no known cause. That's usually an arrhythmia in an ischemic setting. Personality type, I guess they mean type A. High stress, high strung, high flyers, those would be, and then menopausal status. So are the postmenopausal women usually start catching up to men at that stage in life. So those are non-modifiable. And we just tell people, you can't do anything about them, but the ones that you can modify, you want to hit those. So these are the ones you're going to be screening your patients for. You know, what kind of diet you eat, Oklahoma, we tend to be one of the higher fat consuming states in the union. We're in the top 5. We always make the bottom of the top 5, yeah. So diet, so it would be diet high in saturated fats. So saturated fats are what kinds of fats? What foods would we find them in?
Butter.
What? Cookies? Okay, why why cookies? What made you say cookies? You're not wrong, but what would be?
Because it has butter.
Good.
I did a nutrition. My brain is like on.
Okay, butter and what else? I'm sorry, now she turned red.
No.
What do you call it when they're not?
Saturated.
It's got preservatives and all that. so
Okay.
it's really good.
Anything else that we use to hold all that batter together?
Sodium and something else.
No. Okay, so saturated fats, it's easy when you think saturated fats, think animal source fats, okay? Or fats that will stand, that are solids at room temperature. Okay, so butter, lard, Crisco, bacon. So animal source fats, so, and things that are made from them. So cheeses, actually milk tends to have the butter fat in milk is a saturated fat. The yolk of an egg is where the fat is, and that's higher in saturated fat. So those are the animal source fats, or were saturated fats. So why do we care about saturated fats?
They clog up your arteries
Why do they do that?
because they're solid at room temperature, so when they're inside your body, they...
Well, that would sound reasonable. What they do.
Tails. They
They
have
what?
straight tails, and so they like stack on each other.
Oh, could be. Not
Yeah.
sure. Okay.
They
Okay.
have a certain, they have a bond that, they have a bond that is harder to break than an
Say
unsaturated.
what?
They have a bond that's harder to be broken than an unsaturated bond.
Okay. So, an easy way to remember them is that there's 2 ways that your body makes cholesterol. You have native or nascent, your liver can make cholesterol. That's its job. And it can take the parts of the bodies that it has access to, and it can churn out cholesterol. But it also makes cholesterol based on what you give it. And so its preferred substance, if you give it a lot of saturated fat, it will turn out a lot of cholesterol for you. So one of the ways that we lower people's total cholesterol is we decrease their saturated fat intake. So the recommendation is that fat be about 30% or less of your calories per day. And of that, the saturated fat be 10% of your calories. So in Oklahoma, we being an agricultural state have in the past been a very high fat, high saturated fat. So if you live on the farm and you got cows and you got milk and you got eggs, then your food was going to come from a higher saturated fat. Saturated fat's also a very cheap way to extend food. So if you're going to fry things, if you're going to take, you don't have a lot of food, if you can fry it, you can feed and more of your kids. My mother put gravy on everything we had growing up. White bread and white gravy. It's my favorite side. I love it. With 4 kids, it filled us up. Okay, so diet, exercise. So majority of the United States people are sedentary. 40% of the population is sedentary. They don't get any exercise. So why does exercise count in terms of heart disease? Why do we care? Why does moving around make it any better or lower risk?
Your heart's a muscle, so you have to work it out.
Okay, so heart conditioning. Anything else?
Greater blood flow, which doesn't clog your arteries as much.
Okay. Perhaps. I don't know. That may be true.
Skeletal muscle prefers fats for energy.
Fatty acids.
Your heart becomes more efficient.
Okay. Okay, all good. Usually keeps your weight down, right? So demand on the heart is less. The other is that exercise lowers C-reactive protein. So inflammatory markers, a lot of our diseases are due to inflammation, so if we lower C-reactive protein, that helps. So exercise is probably one of the biggest, outside of smoking, it's probably one of the biggest modifiable risk factors you can do. Alcohol ingestion, if you drink a lot of alcohol, you usually don't have a really great diet otherwise. Usually people are very healthy, aren't consuming large amounts of alcohol, so there's an offset there. And it can be damaging to the heart at large amounts. Dyslipidemia, as we talked to, kind of in a backdoor way with the saturated fats. High blood pressure is going to make the work of the heart greater. And then diabetes, through a multiple of mechanisms, also increases the risk of heart disease. In fact, 75% of people with type 2 die from a coronary event. So it's the #1 cause of death in type 2. Okay. So those things we want to hit on. We want to modify those risks. And we like to do it in primary prevention. We'd like to hit and get people to practice a more active and low-risk lifestyle. For those people who have these risks, so we don't put everybody on it, but those people who do have high risk for coronary artery disease, then an aspirin daily would be our treatment. And that is based on risk. Did y'all go through the risk calculators? Okay, so I gave you the links there. And I can publish, did he put on D2L, did he put the American Heart calculator? I can put that, it's in an Excel file, so you can plug your numbers in and see where your risk is, or plug your parents in, that'll bring them out. And so you can determine what the risk of having a cardiovascular event in the next 10 years. So if it's 10% or above, then those people we recommend to be put on antiplatelet. Aspirins are most common. Did y'all go through the mechanism? Did you talk about COX-1 and COX-2? So if you look on, let's see. So if you look at the bottom of page 3, this is important because when we tip these balances, anytime you start tipping the balance of things in the body, then you can bring about ill effects that you didn't intend. So for arachidonic acid, which is in the cell, that phosphobilipid layer in all cell membranes, arachidonic acid is part of it. It's one of the precursors for lots of substances we make. So there's two big enzyme pathways, the cyclooxygenase pathway and the lipoxygenase pathway. So the one we're interested in is that cyclooxygenase pathway. There's two major enzyme groups in that pathway, COX-1 and COX-2. So if you follow COX-1 down, you see that if you convert arachidonic acid to prostaglandin H, then you get lots of different prostaglandins. And you know they're all over the body. They regulate a lot of functions in many organs. They also can lead to the production of thromboxane, which is a vasoconstrictor. Physiologic means it's induced by most of the things internal. COX-2 is inducible by trauma, injury, infection. So COX-2, you get prostaglandins that are mostly related to inflammation. And then the lipoxygenase pathway, we get more of the leukotrienes and things that are related to that, the inflammatory, that part of inflammation. So at low doses, if we knock out COX-1, we allow COX-2 to be predominant. We knock out, at low doses, we knock out thromboxane, and so we get a decrease in, let's see, I think I gave you a picture of it. That's further over. So our preference is to be on COX-1. So if you were several years ago, 10, 12 years ago, we had a lot of COX-2 inhibitors come out. They're very potent, very good. Pain, anti-inflammatories, very good, especially for people that have osteoarthritis or joint inflammation. But guess what? When we knocked out COX-2 and left COX-1 predominant, then what do you think happened? The incidence of heart disease went up. So they had to take some of them off the market. Some of them, like Celebrex, still is on the market, but it carries warnings about the potential to precipitate heart disease. You get it with the NSAIDs too. If you chronically use the NSAIDs, you knock out more of the COX-2, you can get higher risk of cardiovascular disease by using the steroids chronically. Some of them, like naproxen and one other, I'm blanking, but those carry a lower risk. So, how these keep in balance is important. Higher dose amounts will have different effects on those two systems. Okay. So atherosclerosis, have you had pathophys of atherosclerosis? Okay. So if you look at page 5, you've got some pictures there to kind of refer to. So what do you take away from atherosclerosis? What are the major things that are happening there? When does it start? When you get to 50? No? Do you probably have some of it? Yeah, you probably do. You probably have fatty streaks, foam cells already in your arteries. Yes, yes, you too, Ashton. It is scary. That's why you want to, so it counts now, counts all the time. Okay, so you get fatty streaks, and where do those come from? What's causing those fatty streaks? Cholesterol does what? So cholesterol is important. All your cells are made out of it. If we wipe it out, we act like it's the worst thing since a meteor that hit and knocked out the dinosaurs. But cholesterol is part of every cell. If you didn't have cholesterol, you'd be little puddles on the floor. Okay, so cholesterol is important. So it's part of all the building blocks. We make a lot of our endogenous steroids from it. So what happens to that? Why is that cholesterol bad? What is it doing that gets us in trouble?
LDL is released, and then LDL migrates into the macrophages, and then the smooth cells go over there, and then they form a fatty streak.
Okay, so LDL for some reason migrates in the intima of the blood cells. And there, anytime something is where it should not be, what's the body do? It tries to get rid of it, or it tries to contain it. So like you said, so inflammatory cells move in, we lay stuff down over it, and we try to contain it. But what does that do over years? What happens to those fatty streaks?
Get bigger and
They get bigger, and then if they get big enough, they start to impede on the lumen of those arteries, right? Okay. So then we get flow gets disrupted. We also get this kind of turbulent flow. Instead of laminar flow through a vessel, which is very smooth and flows in layers, we get this more bumpy, turbulent flows. We can get little eddies where clots can occur. Okay. So what happens if those lumps or those plaques get big enough? What's the real potential that can cause heart attacks or death? That's what? Okay, so those, if you baked a pie, have you ever done a pumpkin pie or a sweet potato pie? You've eaten them, though. Okay, so when you are making a pie, you really, especially for a pumpkin pie, when you take it out, you want it to be really smooth on top, right? And if it cracks, you're like, it still tastes the same, but it doesn't look as pretty. So that's what happens with that fibrous cap that is over that lipid mound, is that it splits. And when it does, it starts attracting, sends out cytokines, and so you get platelets that are attracted to that, breaking that fibrous cap. If you get enough platelets and a big enough plug, then you get an acute closure of that artery, and that's usually what's thought to be the cause of sudden death. So that's what we want to do. One, with statin-lowering drugs, we're trying to stabilize that plaque so it doesn't grow. We can get it to regress a little bit, maybe a couple percentages, not big, but even that small amount will matter. But we want to stabilize it so it doesn't rupture. And we give antiplatelets to keep those platelets from sticking together. And so even if a rupture occurs, we don't get so many platelets there that they can then obliterate the vessel. So that's what the pictures on page 5 are showing you, is that action that we're trying to avoid. Okay, so aspirin is considered first line. We use a dose of 81 because we get that low impact on COX-1. We get that preferential blocking, and then we can knock out thromboxane's effects. We call it baby aspirin because that's who we used to give it to, but you all know that we don't give aspirin to babies because they are at high risk for what? Reyes syndrome. Very good. Reyes. Okay, so with aspirin, it's an irreversible. Once it exerts its effect on a platelet, then it is there for the life of the platelet. And platelets live about how long? About 7 days. So an aspirin effect takes some time to wear off. So you've got the COX-1, you've got causes platelet aggregation, COX-2 inhibits. So we're knocking out COX-1 to allow COX-2 to play in our favor. Adverse effects, so if you've ever taken aspirin, you know it can upset your stomach, or it can cause bleeds. It's particularly from the stomach or the intestines. It can even cause a bleed in the brain, it causes stroke. Want to reduce those, or we want to identify those patients and use other agents if it's in their benefit. If you have patients that are aspirin sensitive or aspirin allergic, then you can go with clopidogrel or Plavix. The dose there is 75 milligrams a day. The aspirin dose I do want you to know, because we're just going to hit it now over and over and over again, so know that dose. Also know the Plavix dose, there's only one dose, 75 milligrams every day. It works at a different place than aspirin does. It's an ADP-induced platelet aggregation. I've got a picture over in a couple of pages to show you. It does interact with the proton pump inhibitors, so be careful in using them together. People will often use them together because Plavix is pretty upsetting to the stomach as well. If you look on page 7, one thing I want to bring to your attention is clopidogrel is a prodrug. So what does that mean? What are prodrugs?
It has to be metabolized by the liver to be activated.
Has to undergo some conversion, usually it's in the liver, to an active metabolite. So here it gets converted, if you look on that top, it's about 15% of it is converted into an active metabolite. The other metabolite is not active. The reason I bring this up is that there are multiple P450 systems, those cytochromes that are involved in the conversion from inactive drug to active drug. And some of those have very variable genotypes. So some people are very poor metabolizers of that prodrug. So if that's the case, what, in terms of prevention of cardiac events, what would you expect to happen in somebody who was a poor metabolizer of the parent drug? You've got a drug, it's inactive, it's got to be metabolized by multiple steps, and you have a phenotype in a person that makes them a poor metabolizer. Is your ability to prevent cardiac events going to be better or worse?
Worse.
Worse. So there are about 40% of people, 20 to 40% of people that are called poor responders, and it's due to those phenotypes. Those people are going to not get the benefit, as much benefit from the drug as those who are more active or better metabolizers. So you're going to get people who are going to fail Plavix treatment. There's a picture on the bottom of page 7 about a platelet plug, kind of shows you what it looks like. You've got the platelets, and then you got fibrin just laying all over it to make it a clot. Some clots are fibrin rich, some of them are platelet rich, some of them are thrombosis, or more red blood cell. So clots will differ in their composition. And we'll see that in some of the other drugs, whether or not they are active and can work. Page 8, there's some other diagrams. I just pulled things off that I thought might make more sense in terms of looking at how the drugs are working and what they're doing. So I'll let you look through those. Okay, so let's move over to page 9. That's primary prevention. So it's identification of risk factors, modification of those risk factors that can be modified, and then antiplatelets for those who are at high risk. Okay. So let's move on to chronic stable angina. So just general overview. So this is when the demand for oxygen by the heart exceeds what it is able to supply. Pretty simple, but many things that go into it. Angina is a reflection, or probably one of the most common manifestations of heart disease. When we get to diabetes, we'll talk about the fact that many people, especially older diabetics that have had the disease long periods of time, they may never have chest pain. They'll call it silent ischemia. So if you put them on a treadmill and you hook them up, or you put them on an EKG, they will have ischemic signs there, but they'll not complain. So that's a real problem in the diabetic population. So there are silent MIs or silent ischemia. That's the reason for them. So angina is due to the narrowing of those arteries. Most people that have symptomatic angina have blockages that are at least 70%. Did he tell you any differently when you all talked about the pathophys? Did you all talk about any other different for high-grade lesions? Okay. So you've covered the symptoms of stable angina. Did you all talk about Prinzmetal? Okay. So, of course, the most common is going to be the stable angina. I haven't seen that many Prinzmetal, but I didn't work in cardiology that much. So stable angina, it's usually been, these are folks that have got angina. Usually it's predictable. They know what things will bring it on. It's usually relieved by nitroglycerin or relieved by stopping whatever they're doing. On the Prinzmetal side, that's vasospasm, right? What other things characterize a Prinzmetal? Younger or older patient?
Yeah.
Younger. Do they have ischemic changes on EKG? No, they don't. Okay. So we're going to treat them a little bit differently. Drugs that we're going to use for chronic stable angina, we're not going to use for Prinzmetal. Goals of therapy, you know how I love those. So that's going to drive our therapy. We want a symptomatic relief when it occurs. So when they have chest pain, we want to be able to relieve it. We want to prevent them from having any other event. So prevention becomes part of therapy. We want to improve their quality of life. So we want them to be able to do what they want to do. If they want to be able to mow the lawn, if they want to pick up their grandchildren, whatever is keeping them from doing what they want now, we want to improve that. Lots of the drugs have a lot of side effects, so we want the most optimal therapy with the fewest amount of side effects so that they'll continue to take the drugs. And then we want to prevent them from having a reinfarction and further ischemic changes to the heart. Okay, so in terms of modifying risk factors, we've talked about some of these. Let me kind of go through. So with smoking cessation, I read one place that said, and was adamant about no smoking exposure at all. Yes, Brady?
Did you say that there was no EKG change for the variant spasm?
That's my understanding. Is that wrong?
I think you said something different today, and
Okay.
the last bullet
What
point
did he
in your chart too also says that there's an abnormal EKG. So I just didn't know.
Yeah, he mentioned
I
during
think
the
just during the
episodes,
spasm.
During the
there's an
episode,
elevated
a lot of times
ST.
you don't catch it though, they're coming in and telling you about it, so I don't think like at rest or in normal.
I think
that
only
you see
during the spasm that you would see it at
And I'm
abnormal
sure that they
condition.
can precipitate that by
Okay.
using drugs, but, okay, thank you for clarifying that.
Oh, yeah,
Lipid management, I'll just wait, we're gonna talk about that, I think, on Friday. Your blood pressure control is gonna be the same for what Dr. Britton told you in terms of goals. Physical activity, we really like to get them walking and moving. The goal being to get them up to about 150 minutes per week. So brisk walking's is defined as like 3 miles an hour. So most patients can work up to that. So we want to get them on a walking at whatever pace they can and advancing that up to about 150 minutes a week. Weight management, moving them towards a better weight, and then the flu vaccines each year. So our medication, controlling angina is directed towards improving oxygen supply, because that then allows them to do what they want to do and allows them to move around and do and exert themselves. And we want to decrease the oxygen demand. So we're going to do that through heart rate, through decreasing contractility or ventricular volume. Did you all talk about the terms preload and afterload? Okay. So we'd like to reduce both of those, the amount of volume we put on the heart and then the pressure which the heart has to work and overcome. Included in the treatment are the vascularization procedures. Did you all talk about those? Stent placement, CABGs, bypass? Okay. In patients who are not at high risk, medical management of their angina is equivalent to having a stent placement or PCI. So and patients would probably prefer that. For patients who are higher risk, they'll get better symptom relief and with undergoing a procedure. Okay, so drug therapy, let's see, we talked on the antiplatelets, I don't know, you'll find I repeated things. So I may just skip over these. Did you all talk about dual platelet therapy, about using aspirin and Plavix together, and the circumstances under which you do that?
I don't think you talked about using them together.
So people who've had a recent unstable angina, they're high risk, or they've had a stent placement, we may use two antiplatelets. We may use aspirin and Plavix together. Of course, their bleed risk goes way up, but it's because you're using different mechanisms of action, then you're going to have a more effective treatment. So anytime we use dual therapy or triple therapy, we're always looking at different points to attack the disease process. Okay, page 11. Let's talk about nitrates. So this is an acute treatment for a chronic condition. So this is somebody who has chest pain. So they have the onset of chest pain. Everybody who's got chronic stable angina should be given a prescription for a nitrate. I can't tell you how many patients I see who don't have it, or they've let it lapse. The problem with nitrates is they're very volatile, especially when they're in tablets. They just continue to evaporate. So replacing those on a periodic basis. The tablets in particular, I ask patients every 6 months, replace it. As soon as you open it, they start to degrade. So making sure they're either carrying a tablet with them or the spray, they can do that. Whatever they prefer, as long as they're keeping it with them. So when you see the patients, asking them for that, and you're usually going to give them 5 or 6 refills. They may run through that in 6 months. You need to know what size they're getting and how often are they using them. It'll start to give you an indication of what their pattern is at home. It'll also tell you is whether they're using them correctly. Sometimes they don't. Okay, so These are, so we want things that are easily absorbed, so we're going to use sublingual tablets or spray. So sublingual just means under the tongue. These are cheap, very common. They come in little vials like they are at the bottom. They come in 25 or 100. They take the tablet at the onset of chest pain, put it under their tongue. Usually it will burn and it will give them a terrific headache within within a minute, because it's a vasodilator, and so they'll complain. Some people will tell you, it feels like the top of my head's coming off. So it's a real intense. I've never taken one, but it must be fairly intense by their just the way they describe it. We also ask them to sit down for two reasons. One, rest helps relieve that chest pain. The other is that they are vasodilators, so people can lose, they can get lightheaded, they can get, I've never had anybody lose consciousness, but they can get lightheaded, so we tell them to sit and to rest and to wait 5 minutes, and then if the chest pain is not abated, to repeat it. We tell them they can repeat it up to 3 times, and then they have got to, if they haven't already called 911, they need to call or be heading to the, well, we don't tell them to head to the emergency room, we tell them to call 911. If 3 doses haven't taken care of it, then they usually are going to need other help or other intervention. So a couple of things, points under counseling points. Keeping the nitroglycerin, if they've got the tablets, keep it in the original container. You see it's dark. You don't see most drugs come in dark, so that usually tells you they're light sensitive. Light will break them down. I usually tell the patients too, when they get those vials, there'll be a seal over the top and there'll be cotton in there. Now, a lot of the patients will leave the cotton in there because it keeps the tablets from jostling around and they don't break down as fast. But what happens is if you're having chest pain, you don't want to have to take the time to take the seal off, get the tablets out, or get the cotton out. The other thing is the cotton will absorb the nitrate over time. So that's another reason to get it. Keep the top on. Then the nitrates that have aerosolized, you're keeping them more in a equilibrium with the tablets. So those are important to kind of recover with patients, especially if they tell you, I put the tablet under my tongue and it didn't burn and I didn't get a headache. They're either doing something wrong or those tablets are they've lost too much of the nitroglycerin. Okay.
Do we need to do something to control the headache, or just
No,
let them
no.
they'll get over it?
Well, I mean, no, because the most immediate thing is taking care of the chest pain. So if it evolves, then and the headache doesn't go away, then they could take Tylenol. We would probably not want them to take a non-steroidal.
Is there any contraindication to like addiction to nitroglycerin?
No, I don't think so. I one time went and talked to a group of grade schoolers, and we were talking about nitroglycerin. I don't know how it came up, but one little boy said, my grandmother takes nitroglycerin, and he goes, I know that's an explosive. Is my grandmother going to blow up? He was really concerned, but it's not that strong. Say it again. Did you have something
No,
else
no.
to add? Okay, so other side effects, so the tingling, the hypotension I told you about, that's why we have them sit. Nausea can occur, tachycardia can occur because if they get too much vasodilation, arterial, then what will happen is their heart rate will pick up. It doesn't happen very often, but the most common are those first 3. They also make a spray on page 12. Some people prefer the spray. Again, it doesn't do you any good if you don't carry it with you.
If the angina is caused by an embolus, could taking nitro make another problem? Like if that clot were then able to move to somewhere else, does that ever happen, or is that not a
I
concern?
don't think that's really a major problem, no. trying to decide whether to take a break at this point, because we're gonna start talking about beta blockers. Let's go ahead and take our break, and we'll come back at 5 till